Certainly, one of the things we're certainly excited about here in California is that we are leading in healthcare, and an important part of that is our Medi-Cal expansion. So, just a reminder, everyone, we do have open enrollment in California between now until November 28th. So, if you're interested in healthcare coverage, please check out Cover California. But also, another essential part is our Medi-Cal program. In fact, Cover California folks will help you if your income level allows you to be qualified for Medi-Cal. You can be signed up for Medi-Cal as well. And I actually want to thank the Department of Healthcare Services for the close collaboration with Cover California to be sure we try to create a seamless experience for Californians. Now, here in California, though, just to recognize Medi-Cal now covers actually about a third of all Californians, approximately half of all children, half of all deliveries. And in fact, Medi-Cal is now the largest, essentially, health plan in the state. And to be frank, it's actually our single payer system for many communities here in the state of California. And that's why it's so important that we ensure that there's accountability for access and quality of Medi-Cal. I also want to make note that over since 1982, we have moved more and more people in the Medi-Cal program into managed care plans. And that apparently is not necessarily a bad thing, but that also means that our oversight of the Medi-Cal program needs to focus on what's going on with our managed care relationships with our agencies and with the state. So I think right now, I think approximately 80%, maybe just a little under, are actually in Medi-Cal managed care, including many of our most vulnerable have been shifted as well. So today's hearing, we're actually going to focus on two very important aspects of our Medi-Cal program that relate to access and quality. And those two aspects are, one is that, as mentioned, since we have so many people in managed care, how do we set the rates? Because we essentially, through contract with managed care plans, have put responsibility upon these plans to help oversee within the guidelines that we set out in the contracts the state sets out, the care of patients on Medi-Cal. So when you sign up for Medi-Cal, you get assigned to a plan in many cases, and that plan is who you deal with in terms of being sure you can see a doctor on time, you have who's in the specialist network, and specialist, many other things as well. And so that framework in which we set the rates as well as the parameters under which the health plans operate has a tremendous impact on the quality of care. And then the second aspect is what is the oversight we're doing about adequate networks? Because what we're saying as the state of California to people on Medi-Cal is we're saying that when you sign for Medi-Cal, you're going to be able to get health care. So what are we doing to ensure that there are enough providers, enough doctors, hospitals, other healthcare providers that are in the plan, including the right distribution in terms of geography and specialty, as well as the type of providers that you are going to be able to get timely care. And so these two pieces do come together because we're going to be hearing first. I want to thank Mary Cantwell, who's Chief Executive Director of the Department of Healthcare Services. She's going to be speaking about Medi-Cal managed care rate setting and implementation of new state and federal requirements, including, I believe, some of the requirements regarding adequate networks. We are also going to be asking some of our Medi-Cal managed care plans to come in and talk about their experience as well. And then we also have a panel of providers and consumers consumers as well, who will be talking about their experience. And then I believe, Dr. Campbell, we're going to have you to sort of come back and reflect, yes, on what you've heard and about next steps, and then we'll be taking public comment. So with that, I want to thank everyone for being here, and welcome up for our initial presentation, Mary Cantwell, Chief Deputy Director of the Department of Healthcare Services and actually our Medi-Cal Director. Thank you and welcome.
Thank you. So I got back late last night from the Medicaid Directors Conference, so a little out of it. It's been a long week. Got to hear some interesting talk from the new head of Medicaid and the new head of CMS. If you did not see her comments, I would recommend you read them. Anyways, it was fascinating. I guess that's the best way to say it. So yeah, so I'm first going to talk about an overview of our rate setting process. It is obviously a complex issue, but I think hopefully we can talk about it sort of at a high level that can give you a better understanding of generally how it works. So starting with the fact that capitation rates have to be actuarially sound. So really what that means is they have to be adequate and appropriate and reasonable and match the payment to the risk that the plan is facing. We also, of course, want our rate methodology to encourage quality and efficiency. So those are the bedrocks of the rate setting process. In general, we use the health plan's own experience for each particular population, setting rates for those populations. And so depending on the plan model, the rates may be based entirely on the plan's own experience, and that's what happens with the codes, because there's only one plan in those counties. And then for the other counties, we do have a mixture of basing it on the plan's own experience and the average experience in the county adjusted for the risk mix of the plan. So we set rates for separate what we call categories of age, so essentially just different populations. For all counties and regions, we set rates separately for expansion adults, non-disabled, non-expansion adults, non-disabled children, the seniors and persons with disabilities, non-long-term care dual eligibles, and those in the breast and cervical cancer treatment program. And then in some codes or in the CCI counties, we also have long-term care dual eligibles, long-term care Medi-Cal only eligibles, and OBRA. In terms of the data that we use, so we really have three primary sources of data that create what is called the base data for a particular plan here. And this is usually about 2 calendar years prior to the rate year. And that consists of the encounter data. So that's essentially the claims data that the plan sent to us of every service that's provided to their members in their plan. That can include cost information if the plan pays on a fee-for-service basis. But if the plan pays on a capitated basis, obviously there's no payment for the specific service, so there would be zero price on that. The second piece is a data element that we collect every year. It's plan submitted data through what we call a rate development template. And that categorizes utilization and cost for each population in 18 separate service categories. So things like inpatient hospital, emergency room, pharmacy, primary care, etc. And then the third element that we use to look at is our fee-for-service data. So that's really what makes up the base data. We also will be looking at more recent financial statements of health plans to really judge the financial health of the organization and see if there are things. So the actuaries will use that data to create this base data set, which is essentially, again, using the utilization and encounter data. And they'll analyze the unit cost, the utilization, and the per member per month cost of each of those categories of services for each population group. After that's created, they will make adjustments to first trend it forward to the rate period that we're talking about, because again, the data is about 2.5 years old. And so trend will be placed on both unit cost and utilization. And then additionally, if there are other changes that are necessary, if policy has changed, if rates have changed, we use adjustments called program changes. So a couple recent examples of that are the mental health expansion in 2014 and the expansion of non-medical transportation this past July. We also have a few what we call efficiency adjustments. One is related to pharmacy costs. The second is preventable admissions. And the third is related to our dual eligibles and making sure we're pulling out costs that Medicare is paying for. When the final plan-specific, population-specific rates are completed, for the non-coast counties, again, as I mentioned, it's not just their own data. So 30% of their rate is based on their own experience. 70% is based on the county or region average. admin or reasonable trend, they actually certify to a range, and then we can pay anywhere between the lower and upper bound of that range. Beyond those regular monthly capitation payments, there are circumstances where we do supplemental capitation payments. That's typically when we have either new services where the risk and utilization is unknown, or in some cases, like with maternity, the risk between plans is never going to be known, and so it's always going to be a supplemental capitation. So we have 4 currently for 17-18. We have behavioral health treatment is a supplemental capitation. Hepatitis C treatment is a supplemental capitation. In non-coast counties, all maternity events are supplemental capitation. And then in the coordinated care initiative counties, for the home and community-based services for non-duals, we have a supplemental capitation. Those supplemental capitation rates are set with the basic same principles as the base capitation using plan experience and trend and all of that. So that's really the overview of how we do the rate setting. I do want to talk a little bit about our process with the plans. So as you hear, right, we have all of this data from the plans. We have individual calls with health plans about their rate development template, making sure that us and the actuaries in the plans all understand what the data is saying. When the data doesn't match up with the encounter data, how do we sort of account for that? And so we do all of that. But we also, over the last several years, have really made a commitment to be more transparent and collaborative with the plans. This really started in 2013 with the optional expansion. We created a work group in collaboration with the plan associations, where we actually had a core group of CEOs, CFOs, actuaries who got together and we really, in detail, talked about the methodology for rate setting. What data should we use? How should we use it? Etc. And that was really fruitful, and I think we all felt like it resulted in some really good things. So we've continued that work group. It's expanded beyond just looking at expansion. And now essentially my team uses that group with our actuaries to really vet new methodological changes, issues that we're seeing, and really get the insight from the plans who are really the ones experiencing this as to what is the best way to set the rates. So I think the plans would agree, but I certainly feel like it's improved our process significantly, and we continue to have that group meet fairly regularly during the year. So that's the rate setting. So then quickly turning to the network advocacy. So as was noted in the background paper, the Medicaid managed care final rule had new requirements for network advocacy for Medicaid managed care plans. So prior to that rule, obviously Medi-Cal plans in California had to follow the same network advocacy standards as the non-scheme program. The managed care final rule actually requires additional standards that are not required under non-scheme. So just to briefly touch on those, so it requires specific time and distance standards for primary and specialty care for both adults and pediatrics, for behavioral health for both adults and pediatrics, OBGYN, pediatric dental, hospitals, and pharmacy. We also have to have timely access standards, including newly for long-term services and supports where a beneficiary travels to the provider. So these standards apply not just to the medical managed care plans, they also apply to mental health plans, the drug Medi-Cal waiver, and dental managed care. CMS didn't require specific standards. What the standards do for certain time and distance provider standards is they categorize them by population density. So there's 4 categories: rural, small, medium, and dense. And those are laid out obviously in the background paper. In addition to that, we had to identify which specialists were we going to say have to meet these specific provider time and distance standards. There's actually 16 core specialties that we will be measuring individually, things like dermatology, oncology, hematology, psychiatry. Again, don't need to list them all. In addition, we had to establish a process for if there needs to be an exception to the standards. Knox-Keene does this today through alternative access, so we also have that process. And then I'll just note that in AB 205, the standards do sunset in 2022. And that was agreed upon by all of us as we need to actually see what's happening. How are these standards working? Do they make sense? And so that we would all have to sort of come back to the table and talk about them again in a few years. Another new requirement under the managed care rule is that states are required, I'm actually personally responsible for certifying to the adequacy of the networks for every single managed care plan. So they all better have their good networks. So that is new. We used to only do network certifications for new populations and new services, but not a revalidation of the full network every year. So obviously a pretty big change, and I think one that is beneficial in sort of understanding what are the networks looking like. So we have a monthly provider file. I think we talked about it earlier in the budget committee process earlier this year that we've instituted that really is giving us a lot of good detail about every provider, their availability, where they're located, their accessibility, again, their language, cultural competence, all of that kind of stuff. So we will be utilizing that as the basis for doing the network certification. So the plans do submit that on a monthly basis. We're in the process of developing the final way we're going to do the certification. We have to do it before July. But that will be based on the monthly provider file. We'll also be looking at we will be looking at matching the encounter data to the provider file to make sure that if a provider is listed in the network, we're actually seeing encounters being provided by that provider, so it's not just a name in the book, but it's actually a provider who's taking patients. We'll also monitor, in terms of ongoing monitoring, look at things like continuity of care requests, grievances and appeals, out-of-network requests, IMR, state fair hearings, and things of that nature. So we'll be doing that at the DHCS staff level. In addition, we have the required external quality review organization who monitors timely access and network adequacy. And so they will be doing quarterly surveys of timely access starting in 2018. So we'll continue to publish those reports as we have in the past on our website. So I think with that, I will stop and let you ask me whatever questions you have.
Okay, thank you so much. Actually, just one quick question related to what you just said.
Yep.
You said external quality reviewers. Which organization is that?
We use HSAG as ours.
HSAG.
HSAG. It stands for something, but I don't know what it stands for.
Okay.
Health Services. No. That's right. Okay.
And actually, just another question related to that. Are you still doing CAP surveys on Medi-Cal managed care plans?
Yes.
Okay, so the last report.
EQRO does those for us as well.
Okay, the last report I saw from the agents from the ATS was from 2013. When's the next one coming out?
I would have to follow up. I don't know off the top of my head, and I don't think I have that here.
Okay, you can get back because that.
Or the plans might know. Well, how often we do it.
Okay. Well, the last report from the agency is 2013, which is actually pre-expansion. So.
Okay. Yeah.
So
we'll follow up on that.
Okay. All right. So I want to thank you so much for your presentation. I do have several questions as we're looking at things. So let's just start with the rate setting. I appreciate your description of the rate setting. So I guess one of the questions I have, and I understand that part of what you're doing is you're looking at past experience and then trending forward. So one of the concerns I have is that if your past experience has deficiencies, the plan's not meeting certain standards, they have gaps. We're hearing from people frequently, and it's been in the media, and policy people have noted that that basically people in Medi-Cal have a harder time finding providers, particularly I think on specialty and some other types of areas. So, and that there's access challenges related to that. And so if you're taking past experience, how are you correcting for deficiencies in access moving forward. So I guess the first question is, what kind of oversight are you doing on plans to ensure that, and when we talked about network, that those two come together eventually, but if they're, in terms of access deficiency, the data you look at, and how do you incorporate that, or do you incorporate it at all in trying to make adjustments in your rate setting? Because if the plan's historically having problems with people not being able to get to a specialist or a particular type of specialist, or some people not getting primary care, and we use that experience as how we move forward, then essentially what you're telling the plan is that you have a problem, but we're not giving you resources. Now, then there's of course the accountability of how to be sure that if you give additional resources to the plan, that they're using it for that. But so how are we in rate setting looking at potential deficiencies and then being sure that the rates provide the resources to address those deficiencies?
Sure, so I think a couple things. I think first is sort of away from the rate setting in terms of the actual oversight and monitoring, right? We monitor access, we track grievances and appeals. Again, we have the monthly provider file, we make sure they're meeting the network adequacy standards. If they are not, we first offer technical assistance to try to help them figure out, are there providers they could be contracting with them that they're not? What are the challenges with that? If technical assistance doesn't get them back into compliance, we do corrective action plans. And that can be on access, it can be on quality, it can be on financial issues, and work with the plan to actually achieve those outcomes that are necessary. So if they need to increase rates in order to or they need to contract with more people, we see that they do that before we say you're out of being under the corrective action plan.
Okay, so what percentage of our managed care plans have corrective action plans related to inadequate access? Is it something that most plans have a corrective action, or a small minority?
I think we have 4 plans under corrective action right now, but I don't believe those are all access related. That's a combination of all corrective action plans, but I can follow up on what they're on.
All right, and how broad or narrow they are. Okay, so essentially, right, it's the plan. Our work with the plan is that they meet their obligations. And then to the degree that means they spend more, that then flows into the data, right, to move forward. We have also at times, to the degree we've actually seen substantial issues where a plan couldn't maintain, for example, their hospital provider network or something because the hospitals or the doctors or whatever were requiring a significant rate increase. We have made then adjustments. Besides the trend factor, as I mentioned, there's those program changes that we do. So the degree we're seeing something like that, we do have that opportunity. We have in the past made some adjustments when we've seen sort of that substantial impact. So recognizing that if it's going to take 2.5 years for the data to reflect that increased cost, that if it's not a small amount and it's a large amount, we sort of need to adjust for that sooner rather than later. So we do that in the rate setting as well. Okay, because I think some of the challenges that I see just in my own district, we had a reproductive health provider who closed down because the rates were too low and she couldn't keep the doors open. We have challenges getting surgicals time for dental, so it's a combination. Obviously, they get paid on the medical side for the surgical suite to do, and that still is an ongoing issue. But I also note, that's why I was asking about the CAP survey, is that as I'm looking at the results from 2013, and that's the most recent that's out, so I'm curious when the next one is that the vast majority of Medi-Cal managed care plans, not only on rating for all healthcare, but on specific evaluations around access. They're surveying the patients themselves, the families, and are basically ranking in the bottom 25th percentile. I mean, you see, basically 1-star plans, and in fact, generally about half or even more than half, and then probably about 3/4 are 2-star or below. So I can't imagine that, and we of course have, since the expansion, the California Healthcare Foundation survey actually is reporting that the number of physicians actually accepting Medi-Cal has, even though we're increasing the number, has actually decreased. And while this is sort of old data, I know that in my own field of pediatrics, we have the lowest participation rate of private practice pediatricians of any state in the country. So I'm trying to reconcile the fact that we've had these very clear issues with access. I mean, it's not, both anecdotal but also systematic, and yet why aren't we changing the curve on this? And so when it comes to trying to figure out
Heidler Live 3 is
what are we doing? So I'm hearing only 4 plans for corrective action, yet I'm seeing half plans here being in the bottom tier for access, and we're hearing numerous reports of access problems. What are we doing about them?
I think, one of the challenges that we have, right, is it's the difference between sort of when we hear challenges about access and then what we're actually seeing in the data and the plan's experience.
Well,
and that's fair.
Data. I mean, I don't just depend on anecdotes.
No, and I appreciate that. And so I think, the increased monitoring that we've been putting in with the provider file, with these new network adequacy standards, I think is giving us a better insight into the network that we're seeing.
So let me ask you, is the department actually setting performance standards for the plans? So specific, like if you fall below this line, I understand,
Yes.
technical assistance first, but, are those public?
Yes.
Okay, so we'll have to see those.
Yep.
Because I think that it's very important that we not just monitor, but that we act on the data that we have.
Yeah.
Right? And I want to be sure that our rate setting process, so actually network access allowed, that's the outcome end, at least part of the outcome end, and then looping back to are our rates appropriate? Of course, we want to be sure that the plans themselves devote those resources to being sure. In terms of your data collection for your plans, obviously you hold contracts. We've had some challenges on DMHC last year. Reported that their ability to actually ensure that plans were following the Knox-Keene standards was somewhat challenged by the lack of appropriate data they were getting from the plans. How are we doing in Medi-Cal?
Yeah, so it has substantially improved over the last couple of years. I think, as I mentioned, at the beginning of this year, we instituted a new provider file that really gets much more down to the granular level, lets us see the overlap between plans, not even just between plans, but also docs and different IPAs. So we're actually able to have a better view of the network, and using that now to monitor, to do our network certifications. We're still in the final stages. We have some plans who struggled to utilize that file, but we're working on creating some dashboards that I know you guys will be very interested in, to sort of see like how many doctors are participating, how many are taking new patients. My hope is that we'll have that for you when we start the budget process in January. My team knows that if they're listening, they're hopefully busily working on the data. And so I think it is substantially improved, and I do think because we have that direct oversight and relationship with our plans, I think we have more access to information. Obviously, we share what's appropriate with DMHC as well to sort of work together to monitor those things that we both are responsible for. But I think we're seeing a substantial difference, and I'm really excited about being able to bring that kind of information to you and say, well, here's the plans that are struggling, or look, actually, the reality is this is what's happening, and maybe it's certain geographies that we need to focus on. So I think that that's going to be an important tool for all of us, not just the department, but also the legislature and other stakeholders as sort of a transparency view into what's happening with our health plans and their networks.
Well, I appreciate that. In terms of on the network adequacy side, I think there have been some challenges with accuracy of provider networks. So, and they said that you're trying to do figure out mechanisms to ensure that those are accurate.
Yep.
I guess in terms of as you're looking at network, actually, I think one of the challenges that may come up is depending on, are you, in terms of exactly how many patients are actually assigned to a particular provider, not just by the plan for that one product, but across multiple products, and of course they may be taking other plans as well. And actually, let me just give you an example of something that that we may need to work about. And actually, so for example, Knox-Keene, I understand you have a ratio of 2,000 patients per primary care provider, I think is the standard. I would point out, because I did health services research, workforce research before, that a study done by the American Academy of Pediatrics, the Practice Research and Office Settings Network, looking at the average panel size of a practicing one FTE pediatrician is actually 1,600, right? So if you actually assign 2,000, their typical panel size, there's going to be some variation depending on the pediatrician, this is 1,600. So that means you, by definition, 400 kids who are assigned probably aren't really getting in, because that's bigger than the whole panel. Then the challenge is that if you have a contract, if you're saying, okay, now we have that ratio, and we have that ratio for our Medi-Cal plan, hopefully that's the only plan they're taking, because otherwise there's a whole bunch of other folks. So are you getting data from the plans? And some of the plans, they may just be Medi-Cal only, so that's all they have, but are you actually asking the plans in terms of all their products at minimum, how many people are assigned to particular providers, not just on their Medi-Cal piece, if they have other products, private or other things, so that you know that how do you count that FTE? Is that going to be something that they actually assign 4,000 people to the person, and it's 500 or Medi-Cal?
I know that we are doing it across, as I said, sort of within Medi-Cal, but I don't know the answer to that. I don't know, maybe when the plans come up, they probably know better. I don't have all the technical details, but it's a fair question, and I think it's one of the reasons why at least we were trying to improve the that insight into just within our own plans or within the own IPAs, because I think given California's delegated model, it can also be the same doctors in 3 different IPAs and with the same plan, and how do we make sure that they're not 2,000, 2,000, 2,000, 2,000, which would be a huge problem. And then also, again, checking to see who's open to new patients and who's not, who has closed and open panels, I think are more insights. But I will have to check on the other lines of business, or how we would have that information, or and certainly look to my plan colleagues to.
And maybe that's something that ETS can work with BMHC, who also has the private side of things, but ensuring that our network adequacy standards are
really being met.
Right? So it happens that it works multiple ways, and we do have a delegated model, but being sure that we're not overly basically counting the same physicians over and over and over again, and that because the bottom line is that we know from the CAP survey, which is a survey of patients, that we're not doing so well in terms of able to find providers and being able to get there in a timely manner. So that's so we know there's an outcome out there. Something's happened in between there, and that needs to be followed up on. I guess the other question I have is that in terms of the actually on the rate setting, is that something I understand? Is that something you contract out to Mercer? How much does Mercer do? How much does the agency do?
I think probably now we're probably at 90% of it being done by Mercer. We have a few in-state actuaries. I think the reality of the amount of work and the complexity and the number of people in terms of actual resources, Mercer does set Medicaid rates for 29 states across the country, so just their knowledge base is just deeper, and they can often have an easier time hiring actuaries. So we have shifted more to them, but I think that's resulted in an improved rate setting, and again, I think more and then more transparency and collaboration now as we have these work groups with the plans. But yes, most of it is done by Mercer at this point.
Okay, so I guess since they have the expertise, perhaps it'd be good to have them speak for themselves too, right?
I'm sure they'd be happy to come speak to you.
I appreciate that. I hope that actually that you can have Mercer here perhaps next time with you and help answer some questions. That'd be great. And in terms of, I do have to mention there was a recent LA Times article, and I know the plan will be coming up here a little bit, and we may have some things they want to say about that. That talked about, the Medi-Cal expansion. I think the headline was that they made a lot of money, and I know that the department's looking at that, and there's a medical loss ratio that'll be applied and so forth. But as we're looking at this, so on one level we can say, well, they made a lot of money, and the state needs to claw back that money, right, and so forth. But the flip side, I would also say, now, I think that the question is, should the money be just clawed back to the state, or should the money actually be put into better provider access, right? And so as we're looking at their things, I think it's important that if their provider access is fine, and the state can say, okay, well, actually, we need to save the state money. But if they have access problems, you should make them take the profits and put it back into provider networks, right? So what is the HCS doing in your evaluation of the situation to be sure that ultimately, because that's why we have a Medi-Cal program, that the patients who are being seen by those plans that the appropriate resources are put in to be sure that they have the kind of access that they deserve?
Sure. I think, obviously that article was challenging for us. I do just a couple points in response to that. I do think, although it was mentioned, it was not as clear, but we're talking about a brand new population. We were utilizing actually the experience for the low-income health program because we had 700,000 people, right, day one. So when we were looking to set those rates, we were looking at that experience and saying, these are expensive people. These are sick people. And so we overshot it, but that's why in agreement with CMS, we had this risk mitigation strategy. It was in place for the opposite too. If we had undershot, we would have been paying plans more. And so, I think as we all saw, right, that population grew from 700,000 to 4 million. And I think over time really was not as sick as we had originally seen in the original group. And so the rates have come down almost 50% since that time period. Although continuing to make sure that we're not overly cutting to the point of, it's going to harm access, but really how do we get to that right balance of, and now that we're looking at their actual experience, because again, we had to use other data, right? We're using other experience. And so I think that's what's working on that. I think in terms of what our obligations are with CMS is very clearly specified about after the time period is over, if the plan has not spent the money, right, we have not, it's all federal money, it's not even our money, right, to return that to the federal government. So we are working with CMS and with the plans on the methodology for how do we make sure we're capturing the costs appropriately so we're not, taking back too much, but if they actually have money, and I think you'll hear from some of the plans that they would like to pay us back because it was too much. And so we're working on that, and I think we'll probably be seeing at least $500 million, if not more, being recouped for those 2.5 years.
I think one of the things that as we're looking, and clearly, in terms of looking back, but also looking forward, I think one of the challenges that I want to be sure that we're keeping an eye on is, so people say, we're looking at last 2 data to project forward. But the question is in a dynamic situation. So if you have people newly enrolled, they may not necessarily always be accessing as much because they're not used to it, right? They haven't had it before. So, while certainly I think we've worked hard to get people enrolled, but there's also the part about educating people how, and frankly, in the long run, it will save us money because we're trying to get people in to be sure to extend chronic diseases and so forth. But I want to be careful that when we're looking at our past experience, that not we're baking in problems that are in, and I think that's fundamentally, the challenge that I'm I'm concerned about the rate setting process in terms of being sure that we're not continuing to bake in problems. So actually another issue, our Medi-Cal rates now, frankly, if we have the access is fine, low rates are fine. We shouldn't pay more if we have to. But if the Medi-Cal rates are so low, and that's baked into the experience. In fact, I think it's interesting that I assume Medicare tries not to spend any more money than it has to, and their rates are higher. And actually, I think our health plans on the commercial side, I'm not sure that they just want to keep handing money out to providers, right? So they're trying to negotiate the best rates they can, but yet those rates are still higher than so. Medi-Cal being a third of all Californians, it's not that just that other program that's rounding error that you can cross-subsidize anymore. We have to pull our own weight because otherwise that has a huge impact on our overall healthcare infrastructure because it's so big. So I think those things need to be looked at carefully and being sure that we're not creating distortions or problems in the healthcare system, but most importantly, that we're not creating problems that then impact the health outcomes of the people on Medi-Cal.
Absolutely, and I think to respond to the first issue about do we look at is there pent-up demand issues that we're not accounting for? And again, I think our plans can talk about this, but that's part of those program changes that I mentioned. So I think one of the good examples, I think just because it was a benefit expansion of a benefit that was already being provided in the plan was the mental health expansion of mild to moderate additional services in the managed care plans in 2014. What we actually did was essentially bake in an assumption that the utilization would start off lower because people wouldn't know to use it, and then looking nationally at what other experiences were, what do we expect the utilization to be. So we do that as part of the overall rate setting when we're looking at the different services and what do we expect the population is going to be. That's either the combination of trend or those program changes is really about trying to address what the future needs are going to be, because that's what the rates need to be sound for that future period. So we do take into account that. With respect to the other, I think one of the things that I do think will be interesting for all of us is again seeing the impact of the Proposition 56 money. We have very specific providers and services that will be receiving enhanced payments, and I think it'll be interesting to see what that results in. Do we see expansion in certain areas? I think that's something we all want to learn from to see. Okay, what does that tell us about the rates and the provider networks and what we need to do going forward?
Well, I also am very, very much looking forward to seeing that. We've in the budget process, we've recognized from testimony from many people that we have challenges with access. Some related to rates, some related to other overhead processes and so forth. But certainly going to look with great interest and appreciate the department's work on that issue. Just one other thing I just want to touch on before we wrap up, and I can keep going for a while. I appreciate you going out to coming in after a long flight, and spending time with the CMS director. I'm sure that was a lot of fun. But in terms of DHS, its own process, we talked about the CAP survey. There's also, you have people calling in, filing complaints and so forth. I think there's some concerns about the length of time to respond to some of those. So I think DMHC will respond within, on average, within a month, but for DHCS, it can be several months. What are we doing to try to improve and that response, and also what are we doing in terms of that kind of data that we're getting from people who are calling saying, hey, I'm having trouble finding a provider, I'm having trouble getting care. So what are we doing to try to speed up the response time, and also how do we use that information we get from those calls?
Sure. So to answer the first question, we
this comes to the Office of Patient Advocate. So
so we we have improved our ombuds system in terms of being able to call in. We've thanks to the budget committee, expanded our staffing for that to try to have more individuals be able to be a part of that. So both of those things really tracking how is that, are we improving our timeliness there, both in how long it takes to answer the phone, but also respond. There also are changes with respect to the managed care rule in terms of the grievance and appeal process in general, where beneficiaries now have to exhaust appeals at the plan level before they come to the state. So I think that we'll see what happens with that. Whether that's a good thing or a bad thing, I think it is a question. I think it's cleaner in that you don't have a process.
Geography and specialty, as well as the type of providers that you are going to be able to get timely care. And so these two pieces do come together because we're going to be hearing first. I want to thank Mary Cantwell, who's Chief Deputy Director of the Department of Health Care Services. She's going to be speaking about Medi-Cal managed care rate setting and implementation of new state and federal requirements, including, I believe, some of the requirements regarding adequate networks. We are also going to be asking some of our Medi-Cal managed care plans to come in and talk about their experience as well. And then we also have a panel of providers and consumers as well who will be talking about their experience. And then I believe, Dr. Campbell, we're going to have you to sort of come back and reflect, yes, on what you've heard and about next steps, and then we'll be taking public comment. So with that, I want to thank everyone for being here, and I want to welcome up for our initial presentation, Mary Cantwell, Chief Deputy Director of the Department of Health Care Services, and actually our Medi-Cal Director. Thank you and welcome.
Thank you. So I got back late last night from the Medicaid Directors Conference, so a little out of it. It's been a long week. Got to hear some interesting talk from the new head of Medicaid and the new head of CMS. If you did not see her comments, I would recommend you read them. Anyway, it was fascinating. I guess that's the best way to say it. So yeah, so I'm first going to talk about an overview of our rate setting process. It is obviously a complex issue, but I think hopefully we can talk about it sort of at a high level that can give you a better understanding of generally how it works. So starting with the fact that capitation rates have to be actuarially sound. So really what that means is they have to be adequate and appropriate and reasonable and match the payment to the risk that the plan is facing. We also, of course, want our rate methodology to encourage quality and efficiency. So those are the bedrocks of the rate setting process. In general, we use the health plan's own experience for each particular population, setting rates for those populations. And so depending on the plan model, the rates may be based entirely on the plan's own experience, and that's what happens with the COs, because there's only one plan in those counties. And then for the other counties, we do have a mixture of basing it on the plan's own experience and the average experience in the county adjusted for the risk mix of the plan. So we set rates for separate what we call categories of age, so essentially just different populations. For all counties and regions, we set rates separately for expansion adults, non-disabled, non-expansion adults, non-disabled children, the seniors and persons with disabilities, non-long-term care dual eligibles, and those in the breast and cervical cancer treatment program. And then in some COs or in the CCI counties, we also have long-term care dual eligibles, long-term care Medi-Cal only eligibles, and OPRA. In terms of the data that we use, so we really have three primary sources of data that create what is...
What I'm excited about here in California is that we are leading in healthcare, and an important part of that is our Medi-Cal program. In fact, Cover California folks will help you if your income level allows you to be qualified for Medi-Cal. You can be signed up for Medi-Cal as well. And I actually want to thank the Department of Healthcare Services for the close collaboration with Cover California to be sure we try to create a seamless experience for Californians. Now, here in California, though, just to recognize Medi-Cal now covers actually about a third of all Californians, approximately half of all children, half of all deliveries. And in fact, Medi-Cal is now the largest, essentially, health plan in the state. And to be frank, it's actually our single payer system for many communities here in the state of California. And that's why it's so important that we ensure that there's accountability for access and quality of Medi-Cal. I also want to make note that over since 1982, we have moved more and more people in the Medi-Cal program into managed care plans. And that apparently is not necessarily a bad thing, but that also means that our oversight of the Medi-Cal program needs to focus on what's going on with our managed care relationships with our agencies and with the state. So I think right now, I think approximately 80%, maybe just a little under, are actually certainly one of the things we're sort of Medi-Cal managed care, including many of our most vulnerable, have often been shifted as well. So today's hearing, we're actually going to focus on two very important aspects of our Medi-Cal program that relate to access and quality. And those two aspects are, one is that, as mentioned, since we have so many people in managed care, how do we set the rates? Because we essentially, through contract with managed care plans, have put responsibility on these plans to help oversee, within the guidelines that we set out in the contracts the state sets out, the care of patients in Medi-Cal. So when you sign up for Medi-Cal, you get assigned to a plan in many cases, and that plan is who you deal with in terms of being sure you can see a doctor on time, you have who's in the specialist network, anesthesia specialist, many other things as well. And so that framework in which we set the rates as well as the parameters under which the health plans operate has a tremendous impact on the quality of care. And then the second aspect is what is the oversight we're doing about adequate networks? Because what we're saying as the state of California to people on Medi-Cal is we're saying that you sign for Medi-Cal, you're going to be able to get health care. So what are we doing to ensure that there are enough providers, enough doctors, hospitals, other healthcare